in the beginning, we did realize our mistakes and learn from them. These are just 4 cases that I'm going to take you through. I have no conflicts of interest and no financial disclosures to make. We know about the intraepidermal blistering disorders. This is the list before you, and my cases come from within this group. This was my first case. She was a 43-year-old woman, referred from surgical outpatient for a growth on the ring finger of left hand for 2 months duration. You can imagine she was lucky. We know how our surgeon friends are. A growth would mean you just take it off. So somehow they referred it. And when we asked her history, she said that it has started as multiple pustules involving the nail fold and spread to involve the ventral aspect of her ring finger. And these gradually developed small, she used the word excrescences. And we translated it as small vegetations which coalesce to form a plaque with pustules at the periphery. She had gradual separation and eventual loss of the nail plate. What would we all think of? You are most welcome to give any clinical suggestions that you have. Well, we thought of these possibilities: acrodermatitis continua of Halopeau, infectious eczematoid dermatitis, pyodermatitis, piostomatitis vegetans, and vegetative pyoderma gangrenosum. And we tried giving her antibiotic courses. She didn't improve. We thought, let's try topical steroids. She didn't improve. But 1.5 months later, she developed painful oral and genital mucosal erosions. Then we had a rethink. And when we did a biopsy, we had pseudoepitheliomatous hyperplasia, the eosinophilic spongiosis, suprabasal separation, and a DIF which was positive for IgG and ICS in a fishnet pattern. I'll take you to another case before I discuss the first one and the second case together. This was a 64-year-old male. He presented with an itchy erythematous verrucous plaque on his right arm. He had similar plaques on his thigh and abdomen for a total duration of around 3 months. These started as pustules, would erode a little at places, and then enlarge to form into verrucous plaques. They all had a rim of erythema. His bloods showed peripheral eosinophilia. A close-up of the lesion. Again, what would we all think of? So we thought of blastomycosis like pyoderma, vegetative pyoderma gangrenosum, and even hypertrophic herpes simplex. We thought maybe as an HIV background or something like that, which is not responding. And when we did a biopsy, we were surprised. We again had hyperkeratosis, acanthosis, papillomatosis, and a suprabasal blister, eosinophil-rich infiltrate. So both our cases were actually pemphigus vegetans localized to unusual sites. We are not used to seeing pemphigus vegetans at these sites. We see it in the flexural areas or in the oral cavity. So there was no flexural involvement and no involvement of the oral mucosa. If we look at the classical presentation of pemphigus vegetans, we realize that it's an uncommon variant of pemphigus vulgaris ES and accounts for around 9% or 10% of all pemphigus cases. The 2 classical types are the Halopeau or Newman, and oral mucosal involvement is either in the form of velvety plaques inside the mouth or the scrotal tongue, as we classically call it. We started looking for literature for cases similar to ours. That has this been reported before? And we encountered, interestingly, 2 case reports of similar presentations. One was from Bangkok, Thailand, and the interesting thing here was that the diagnosis of pemphigus vegetans was made based on histopathology and DIF. The clinical presentation was atypical, but the blood tests for anti-desmoglein 1 and anti-desmoglein 3 antibodies were negative. Now, this is a take-home message for us here as well. This was the presentation this group had in their cases. Then the second report that we encountered was from my friend Ino Schmidt's department in Lübeck, Germany. And this was very similar to what we had seen. And in fact, they had a histopathology again, which had given them the diagnosis. What I have highlighted, I'm sorry, this is a very busy slide. I just copied it verbatim. What I wanted to highlight here is that in the literature which they searched from 1988 onwards, they only identified 52 patients suffering from pemphigus vegetans, and 7 of these showed anti-desmoglein 3 antibodies without any mucous membrane involvement. So classically, as we are taught in our textbooks that you have to have mucosal membrane involvement or flexural involvement, that's not true. You can see some of these cases. And the other thing was that, as I said in the previous case, the ELISA levels, anti-desmoglein 3 antibodies were detected while anti-desmoglein 1 and anti-desmocollin were negative. So the ELISA tests do not go hand in hand with these clinical presentations, and you have to rely upon your histopathology and DIF. Coming to the third case. This was a middle-aged male. He was a known case of pemphigus vulgaris for a couple of years. He presented with a sudden eruption of lesions mainly on the trunk. When we went back into his history, we realized that he had been treated with prednisolone for a flare-up of his disease along with azathioprine daily. And we were wondering, is this the usual that we see when we give patients a course of prednisolone? Is it acneiform eruption? But it was not. One of my young colleagues did a dermoscopy, and what we realized was that he had vesicular lesions which were around the hair follicles. And when we did a biopsy, this is what we found: a split and acantholysis in the hair follicle epithelium, and a DIF showed a fishnet pattern. So this was reported by my department as follicular pemphigus, an observation in patients treated with steroids in the clinical and experimental dermatology in 2017. This taught us some things, that acneiform eruptions are well known as a side effect of systemic steroids, and pemphigus is one of the many dermatoses that exhibit Koebner's phenomena. So what we were wondering was that, is it that the lesions of pemphigus Koebnerize to the acneiform eruptions which were induced by corticosteroids? I think possibly yes. We have a reason for this. Desmogleins are expressed throughout the outer root sheath of hair follicles and dermal bulb matrix. And almost exclusive follicular deposition of IgG with only patchy deposits in the epidermis may be due to increased expression of antigens on the hair follicles compared to the epidermis. I have another quiz for my friends. Any guesses on this? If you see closely, you see basically the inguinal areas are involved. There are some eroded lesions on the picture on the lower right, but the picture on the left also has some blisters. So this was another proof of what we just talked about right now. He was another example of Koebner's co-localization of tinea and pemphigus. This was a patient who had tinea cruris, and he had pemphigus, and he had much more lesions, fresh lesions coming up in those areas where he had the tinea. This, in fact, led us to also publish a paper on the use of plucked hair as possible diagnostic tools in the management of pemphigus. Coming to my last case, this was a 15-year-old male, a student. He complained of painful oral erosions and loss of weight for around 3 months. And he had also periungual painful bleeding erosions for around 1.5 months. All this was associated with gradually progressive difficulty in eating. He had pain and he had bleeding from these lesions. There was no history of prior drug intake, which was a surprise for us. We were thinking he must be having had some drugs. He was thinly built. He just weighed 30 kgs. Systemic examination was essentially normal. And on his hands, I'm sorry, I don't have a close-up picture. He had this distal areas that you see, some erosions around the nail folds, and almost digital pitting-like areas that you can see. Now, what would we all think of? We were wondering, is it Stevens-Johnson syndrome? The first reflex which comes to your mind when you see lesions like this with only these areas, the body is spared. The primary herpetic gingival stomatitis, is it with that, with acral EM-like lesions, or an id eruption, which is tending to settle down? Erosive lichen planus. I have reported a patient of lichen planus involving the nail folds, bullous lichen planus, long time back. And I have also reported patients with selenium toxicity who had nail fold involvement and bleeding like this, but they never had any oral lesions as bad as this gentleman. So we thought of all these possibilities. He had not received any drugs, so chemotherapy-induced stomatitis was much lower down in our list. So we were left wondering. When we did our investigations, to our surprise, his ultrasound abdomen showed a well-defined ovoid hypoechoic mass with multiple internal vascular channels in the right hemipelvis. The MRI showed a well-defined enhancing mass, and a PET CT showed an avid heterogeneous enhancing soft tissue mass. FTG uptake was there. The histopathology then, when we did, the diagnosis was consistent with paraneoplastic pemphigus. Well, just a couple of quick words about paraneoplastic pemphigus. It's an uncommon disease. It's not common, and there is no gender predilection. For us, what was surprising was the age of this child. Normally, it's reported between 45 to 70 years or the older individuals, but the age range may be lower. When you go through literature, you realize that the age range is quite wide, and in the younger, it is Castleman's disease, basically. And malignant or benign neoplasms may lead on to paraneoplastic pemphigus, NHL to the tune of 40%, CLL 20%, and Castleman's disease again 20%, besides thymomas and non-hematologic malignancies. The pathogenesis for this disease is interesting. It has both humoral as well as cell-mediated immunity. That is why you have the spectrum of lesions which ranges from your classical pemphigus-like lesions to lichenoid lesions. This is the diagnostic criteria for some of you who may be interested in a little more of theory. To conclude, I would just like to say that morphology of the autoimmune bullous diseases is not limited to what we classically understand as vesicles bullous lesions or erosions. There may be pustular lesions at times, or there may be vegetating lesions at times. And localization is important in dermatologic diagnosis, but it may rarely change and it may mislead. So that takes us some time to reach a final conclusion. But having said that, as I said, biopsy and DIF remain the cornerstone of our diagnosis. Do not rely on your ELISA test for these atypical variants. And these atypical presentations are relatively commoner in the uncommon variants of blistering disorders. You don't see in classic pemphigus vulgaris changes like these. And the good point is that these diseases do not behave differently from classical disease. Thank you for your patience.